Mm. Oh my God. Good day. Barack, how are you?
Hi, Joe. I'm good.
Nice background.
Thank you.
You built that yourself, right?
Yeah.
And let me just take this off.
How long is his talk, John? Do you have any idea? Because I'm not going to present anything today.
Well, it's very flexible. You know, Atul, as you know, is a very interesting speaker, and he may go off in a certain direction, which I'm sure you'll be okay with, right?
Yeah, sure. No
Yeah,
problem.
he has so many areas of knowledge, you know. I've just been very impressed with watching him over the years. I'm not a neurosurgeon, but you know, everything he says, he backs up in literature. He's written so much.
Yeah.
There's not many neurosurgeons that can say that, you know, really. Dedicated, good memory. He's traveling a lot to Latin America now. We have him Sunday on Cuba Grand Rounds.
Uh-huh.
And they really liked him last week. They did, you know, for them to see him is like big because they
Yeah,
just seen his name. They just seen his name around.
that's right.
But anyways, yeah, I hope to have a few spine guys come by. I don't know if you recognize any names yet, but I'm finding that it will have probably between 10 and 20 panelists, but I'm finding that size is great, is really good. Because my experience with it, there's been more interaction, the kind of like less people. Because I have them with 80, 70, 50. It doesn't seem to be as much. It's funny. It doesn't seem, you know, logical, but that's the way it works. So I'm happy if I have between 10 and 20 panelists.
Yeah, that's good.
So how you been? You been busy?
Yeah, extremely busy. these few weeks extremely busy, and lots of bit worrying, because these days there is an infection going on in our theaters.
Really?
So yeah, almost.
OR infections, huh?
Yeah, exactly. So almost all the patients are getting post-op infections, wound infections,
Wow.
lots of problems. Even young patients dying sometimes after the surgery.
Really?
So yeah, so you had to. I mean, we had a.
Now, is that particular to Sri Lanka or
No. I mean, I think it's in our ICU setup, and only in our theater, these
Oh,
emergency theaters. Yeah, so we had a meeting, and we had to find out the source. So we are planning to implement few things uh,
so
within
you're
the next
probably
few weeks.
you're
Yeah,
doubling up on the hand washing and all that, right?
yeah. We had to find out the cause. Uh, because it's a bit congested, because the volume is very high nowadays compared
Oh
to
boy.
compared to few years back. Now
But
people are
people coming out of COVID coming out and
exactly.
bringing the problems
Yeah.
that they stayed home with COVID, right?
Now actually the COVID is a little bit less prominent topic these days. Uh, not very much.
It's non-existent in most places I've seen
Yes.
lately.
Yeah. It may be existent, but it's not very prominent as it was
Not
before. Yeah.
fulminant. Yeah, it was.
I think it's
We
the
did
same situation in US, is it?
well. It's like it wasn't here. It's really funny. The area and country I'm in, you don't no longer have to wear a face mask on public transportation, public areas. Some hospitals you still do.
Yeah.
They're being very cautious. But generally, it's like it was a bad memory.
Yeah.
So I hope it stays that way. It just seems that you never know what's going to happen nowadays. It didn't seem so changeable before. It was pretty stable, the usual stuff, but now it's all over the place.
Yeah.
But okay. So you have a full schedule, plus you have to deal with the infection problem.
Yeah, so I thought of stopping all these routine cases for the next week, and give a little bit of break. So we had
What the
a meeting.
elective cases you'll kind of back off on?
Yes. So we had a meeting with the administrators. So we are going to have some repairs, because compared to the beginning. So at the beginning, this unit was established in 2018. I can remember. So I mean, compared to 2018, now number of cases almost maybe around 8 to 10 times. So we are operating at a very higher rate, and the volume is very, very high. So that may be one reason, because although the number of cases have increased, the resources and the other infrastructure have not developed parallelly. So that may be one reason. So we had to think of. So we need to look for alternatives as well, because the wards are congested, the patients are everywhere. So we had to think about the wound preparation, because it's a big burden for the ward staff as well, because the number of ward staff have not increased, even though the number of patients have increased. Because now, as a teaching
That was
hospital,
a problem before too. Before that was a problem. Yeah.
So
excuse me, Dr. Excuse me, Sarath. Dr. Shah, are you there? I wanted to see if she's having the infection problem in her. Hey, Sarath, right?
Hi, Sarath.
Hi, Abida.
Sarath was talking about they're having an infection problem in Sri Lanka. And maybe you can tell her about that, Sarath.
About
Yeah.
what problem?
No, I mean, these days we are getting a few cases post-op infections, a bit of abnormal. So most of our patients say routine emergency cases are getting infected. So we were a bit worried these days. Mainly the cranial wounds are getting infected. So
We operate large volumes too, but generally we don't have this problem too much of infection.
yeah.
Not-
Yeah. This is different than normal, obviously, right,
Yeah.
Sarath? Yeah.
Yeah.
So Abby, we're bringing the king to Latin America.
Yeah. On Sunday, yeah. I think it's designing strategy for pituitary tumors. I'll send you the
Okay.
doc.
Yeah. Just send me I'll change it on the banner
Yeah.
and the stuff. Yeah, I think Atul is getting a Spanish accent.
I don't think so. You can tell him that.
Speaking Indian with a Spanish accent. But yeah, they're all excited. The Kuban group.
Yeah.
So how you been, Abby?
I'm fine, just got back.
You know, I'd like to ask you to lecture especially in Latin America. Well, they understand English, so I'm going to be sending you invites, okay?
Okay.
If you want, you mostly do neuroanatomy, or you have other preferences?
No, we'll figure out something.
Okay. Yeah, we'll talk about it later. Oh, good. Saeed's here. You may know Saeed Sarath from France.
We have met before. Yes.
And I think you know him, Abby. The startings of a good group. Hello,
Yes,
hello, Saeed. How you doing?
Fine.
We have met before.
Yes.
I think you know
Yes.
Abby and
How are
Sarath.
you?
Oh, here's
How are you,
Atul.
Sarat? How are you?
Hi, Said. I'm good.
Abida,
Thank you.
Hi,
how are you?
I'm fine. How are you?
Okay, everyone
It's a
bow.
pleasure
The king
to
is
be with
here.
you.
Hello, Saeed. How you doing?
Fine. And you, John? Yes.
I think you know Abby and
How are
Sarath.
you?
Oh, someone has the, or maybe me, have a YouTube on.
Yes. It's all right.
Anybody have a YouTube on? I think someone has a YouTube on.
It was me.
Oh, okay, you got it? Okay.
Hello.
Okay,
guys.
hello, Dr. Gore. You don't
Good
see it, but we're all bowing.
How are you?
You don't see it.
Good morning, John.
How you
Good
doing?
evening, my dears, all my friends and fellow travelers in Sri Lanka. When I say fellow travelers, it means we are traveling together to look for the best treatment for our patients. There is no big or small, no rich or poor. We are all fellow travelers in search of the best treatment for our patients. And we have to help each other, we have to support each other, and we have to go because our purpose is nothing else but our patients. You agree, John?
Yes, Atul, I'd like to introduce you to Sarath. I don't know have you met Sarath from Sri Lanka? He's done a bunch of webcasts with us.
Yes, I've seen his photograph
Hello,
on your
Sarath.
program.
Hello, sir.
Hey,
Hello.
Welcome to Sri Lanka Neurosurgery Grand Rounds. It's been a great privilege and a great honor and a great pleasure to have you on board today. So today I'm not going to talk, so I have dedicated all my time for you. So it's all yours.
yeah,
Right
okay,
away.
I'll introduce you formally in a second. Okay, let's just wait a couple minutes, okay? Let's get some more people here. Yeah, I detect a Spanish accent in your your Indian language, Atul. I
Really?
don't know, you got a little Spanish accent.
Yeah, I've been traveling to Latin America quite a bit.
Yeah, you ought to do a fellowship over there. Go back in time.
How many neurosurgeons are there in Sri Lanka, Saurabh?
It's around 25
25.
total. Yeah.
Very good, very good.
Do you know any neurosurgeons from Sri Lanka, sir?
No, I know one lady neurosurgeon who has been trained in Manchester, who is now in Sri Lanka. Her husband is cardiothoracic surgeon. I know her.
Yeah. Dr. Ruini, yeah. Ruini
Yeah.
Abdegunardana.
Yes,
Yeah.
yes.
I think we have met in 2017. I think we met in UK. I think you were there with Dr. George Samandiras, the Master Symposium.
Yes, yeah.
Yeah. I was his registrar at that time. So I was with him for 6 months.
What do you remember of that symposium, Saurabh?
Yeah, and you were doing live cases. I can remember you were doing 6 cases, not in 30 or 40 minutes. Amazing.
Yeah.
Okay, let's start. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV on the beach. We're honored with the presence of world-renowned Atul Goel in the Sri Lanka Neurosurgical Grand Rounds, headed by a very active video guy, Sarath Munasinghe, who is heading the group. I'd let him introduce who I call the king of Zoom, Atul Goel. Hello, Sarath.
Hi, John. Yeah, thank you very much. So let me share my screen first. Right. Right. So good morning, good evening, or good afternoon, wherever you are, and welcome to another chapter of Sri Lanka Neurosurgery Grand Rounds. I'm from Sabaragamuwa province, so this is basically Sabaragamuwa chapter. So today we have the privilege and we have the pleasure of having a world-renowned neurosurgeon. Is Professor Atul Goel. So I'm very privileged and I'm very happy to have him, very proud to have him on board today on behalf of Sri Lanka Neurosurgery Grand Rounds. I warmly welcome him. I think this is the first time he's joining us. So welcome to Neurosurgery Grand Rounds. So with a warm welcome, I invite Dr. Atul Goel and thanking him, accepting our invitation to deliver his valuable speech. And it's over to you, sir. It's all yours.
Thank you, Dr. Saurath. And we all know Sri Lanka, how beautiful this country is. And we know it is very close to India. But unfortunately, I don't have clear idea about what neurosurgery is going on in Sri Lanka. And I'm sure with this young breed of neurosurgeons like Saurath, like Rohini, and like other, I'm sure there must be several senior neurosurgeons in Sri Lanka, because Sri Lanka, we only know from cricket that they have fantastic cricketers and top cricketers, and it is difficult to beat Sri Lanka at any stage in cricket. So neurosurgery also must be as advanced as the cricket is. Is that right, Saurath, or no?
Yes, I mean, we have a very active and very talented, skilled neurosurgeons in our country. But, you know, sometimes it's a bit unfortunate that we don't see much of them in international arena. So it's, I mean, for example, if we talk about the journals, publications, it's very rarely we see this coming out from Sri Lankan neurosurgeons, maybe because of various background reasons. But we have, I mean, a very talented, skilled, and very active neurosurgeons in our country.
If I want to ask you, how many people in Sri Lanka are doing craniovertebral junction surgery?
I think most of them are doing, most of them are practicing.
Craniovertebral.
Yes.
And
I'm not sure about the numbers, but I have seen when I was in training, they do. But it depends. Like some people, I mean, they only perform few, and some people who are more keen on spine surgeries, they perform regularly.
how many of you do cavernous sinus surgery? Just for my information.
Yes.
Because I want you to now, the Zoom is one, but I want to come to Sri Lanka to see a beautiful country and see what work is going on.
Yes.
And because, I have fellows from various countries, but never from Sri Lanka. That is one thing.
Yes, exactly. So I'm sure most of them must be practicing. I don't know exactly how many of them are doing cavernous sinus, but for example, I have done quite a few, and I know my trainer, Dr. Kularatna, he has done few cases. I'm sure it's not. I mean, not very much, but maybe at least half of them.
Okay.
Out of 25.
Let's get started. Many of you. So welcome Sri Lanka on this program. Many of you have heard me talking on cavernous sinus and tumors of skull base, but I don't think many of you have heard me talking on spine. Of course, on craniovertebral junction, that is different. But on spine, I don't think many of you have heard. So what today I'm going to do is I'm going to present a different format, Saurav. So different format of treatment, a complete revolution. When I use such language, I'm not using just for Sri Lanka, but wherever I go, I talk in this language, in this format. I am going to present an absolute revolution in spine surgery. And I have no doubt that the concepts which I am going to present are here to stay. The other thing I want to let you know that whatever sentence I speak, whatever words I speak are all published in high-profile journals. So it is not just like that. So I want to take you to a different concept. So you have heard about spine surgery. The concept is compression is the issue and decompression is the treatment. This is what the whole world of spine follows. There is no other format. There is no other treatment. Compression is the issue. Decompression is the treatment. And I take you to a different concept that we should not just talk about compression and decompression. We should not even talk about these entities. I am taking you to a different world of spine surgery. I am introducing before you a concept that compression, I'm not talking of tumors and other things. I'm saying compression is never primary and decompression is never the treatment. So this is quite a radical statement, quite a dramatic statement to make, that do not do decompression. So, no spine surgeon in the world will even, will be terrified to hear this statement. But let me see how I can prove this point, that compression is never primary. Compression is always secondary. Compression is always protective, and compression is always reversible. Compression is an indicator of unstable spine. Stabilization is the treatment, not decompression. So this is a concept that instability has to be identified. Compression indicates where the instability is. You stabilize, compression will automatically disappear. It is like inflammation. Infection is the issue. Fever and other inflammation responses are secondary. They are all protective. They are all reversible. You treat the infection, the inflammation and the signs of inflammation will go. And all the symptoms are due to inflammation, not due to the primary problem. The bacteria is not causing any problem. Like similarly, I talked about hydrocephalus in tumor. tumor is the pathology, hydrocephalus is secondary. You treat the tumor, hydrocephalus will resolve. The symptoms are due to hydrocephalus, headache, vomiting, and all those things. Similarly, instability is primary, compression is secondary, compression is protective, compression is reversible. So this concept I want to introduce to you. Music of movement. You see, we should know that movement is life. Movement indicates life. Wherever there is movement, there is life. Wherever there is no movement, there is no life. And in the human body is unique because we stand. All other animals in the entire planet, none of the animals stands. So all our muscles to facilitate standing position are on the back of our spine. Nothing is there in front of the spine in relationship to the vertebral body, in relationship to the disc. There is no muscle. So all the muscles are focused on the back to make the human body stand. Bird, the muscles are in the shoulder. In a four-legged animal, the muscles are in the shoulders or the hip joint. Nothing much on the spine. But human body is different. All the muscles of the human spine are focused on the facets. Whether it is craniovertebral junction, whether it is subaxial spine, all the muscles are focused on the facets. If the muscles become weak, the facets become weak. And there starts the problem. Facetal weakness leads to instability or subtle listhesis. And this is the beginning of the problem, which I am going to discuss with you. So craniovertebral junction is the most, atlantoaxial joint is the most mobile joint. Even in the craniovertebral junction, all the muscles are focused on the facets. C2 spinous process is the largest. C1 transverse process is the largest in the entire spine. C2 facet and C1 facets are the strongest facets in the entire body. If you see the facets of subaxial spine, the facets are the strongest part of the vertebra, not the vertebral body, not the transverse process, not the spinous process, facets. So I want to introduce to you a brand new concept of vertical facetal instability. When the muscles become weak, there is listhesis over the facets, which may not be radiologically identifiable. This instability, there is a telescoping of the spine. And if you see your grandfather, 75-year-old, he's shorter than you today, but he was not short 50 years ago. There is a telescoping of the spine, and that is the beginning, that is the genesis of spinal spondylotic disease. So this concept I want to introduce to you. I want to introduce to you another very fantastic, radical revolution in the craniovertebral junction surgery, a concept of central or axial atlantoaxial instability. There can be instability without radiological manifestation. So this concept is absolutely unique. So we have to know about the facets, and we have to know some facts about the facets. There is one instability called acute instability, one instability called chronic instability. Acute instability has sudden symptoms, pain in the nape of the neck, stiffness of the nape of the neck. Chronic instability can be for 20 years, 30 years. There is subtle, potential, or manifest instability, which may not be identifiable on radiographs, but it is unstable. There are several secondary manifestations in presence of chronic atlantoaxial instability like Chiari malformation, syringomyelia. These are all secondary, these are all protective, they appear to be compressive, but they are not. They are protective and naturally protective. You please read this article of mine which talks about natural protection. So when there is chronic atlantoaxial, I'm not talking of acute, chronic. Acute, there is pain in the neck, but chronic, there is a shortening of the neck. There may be torticollis, there may be Chiari, there may be syrinx, external syringomyelia, short head, short neck, basilar invagination. bifid C1, C2, all these secondary features are children of craniovertebral junction atlantoaxial instability. When Chiari is present discretely or in cohort with syringomyelia or in cohort with basilar invagination, if basilar invagination is present discretely or in cohort with C2-3 fusion, with assimilation of atlas, with platybasia and several other issues, they are all indicators of instability. This fact has never been discussed in the literature. When you see Chiari, you have to do atlantoaxial stabilization. When you see syringobulbia, you have to do C1, C2 fixation. When you see short neck, you have to do C1, C2 fixation. When you see basilar invagination, you have to do C1, C2 fixation. So this is an absolute revolutionary concept. Currently, all these secondary entities are considered to be secondary. They are considered to be pathology. And all these entities are treated by decompression. So I am saying that all these entities are secondary to chronic atlantoaxial instability, and all these entities need craniovertebral junction stabilization and not decompression. And all these entities are reversible and protected. So basilar invagination, the whole world was treating basilar invagination 20 years ago by decompression. That was the treatment. Senior Sri Lankan neurosurgeons may know this, that this basilar invagination was treated by transoral surgery, decompression. This basilar invagination was treated by foramen magnum decompression. So we, in the year 2004, we introduced the concept that this basilar invagination is unstable. This basilar invagination needs stabilization, and this basilar invagination craniovertebral junction can be realigned. So we introduced this term craniovertebral junction realignment. And those who are now doing craniovertebral junction surgery, they know that realignment is the treatment. Decompression is completely not the treatment. So in 2004, my concept was that this basilar invagination should be treated by foramen magnum decompression. That was my concept. So this basilar invagination opened the C1, C2 articulation or joint, remove the articular cartilage, distract the facet, and realign the craniovertebral junction. This concept has completely revolutionized craniovertebral junction surgery. Now, very few people in the world will do transoral decompression. So we have got several hundred patients now where we have treated basilar invagination by craniovertebral junction realignment, and there are several examples that we have. As we move further, now my concept is both group 1 and group 2 are unstable. Where we had described foramen magnum decompression is also unstable. So instability is the problem and stabilization is the treatment. That is my current concept of basilar invagination. And transoral surgery is completely in history books. In 1999, for the first time in the literature, we said that basilar invagination is like C1 over C2 listhesis, like lumbosacral listhesis. Like you treat lumbosacral listhesis, you treat C1 over C2 listhesis by opening the body, intervertebral body's joint, removing the disc or whatever, and then realign, like you do listhesis. So like here, there is Chiari and syrinx and basilar invagination. Listhesis is the problems, stabilization is the treatment, and realignment is the most beautiful form of treatment. And syrinx and all these things which you see here are secondary. They are reversible following a beautiful stabilization. So we introduced a new clinical entity called central or axial atlantoaxial instability. And if you read this sentence properly, you will see that central atlantoaxial instability is present in entities like basilar invagination, Chiari, syringomyelia, cervical spinal degeneration, spinal cervical degeneration deformities, OPLL, and Hirayama disease. So the treatment of all these entities can be influenced if you know the concept of central or axial atlantoaxial instability. So this was divided by central instability was on the basis of new classification of atlantoaxial instability. The only validated parameter of atlantoaxial instability is increase in the atlantodental interval and listhesis of C1, C2, compression of the cord. So listhesis is the problem, instability is the issue, stabilization is the treatment. This is what we said for the first time in the literature. Now we introduce another beautiful clinical entity in this kind of basilar invagination or syringomalia or other things. There is no atlantodental interval disturbance. There is a retrolisthesis of facets. C1 facet is behind the facet of C2. Stabilization is the treatment. Decompression is not the treatment. So this is type 2. This is type 1, this is type 2. Listhesis C1 over C2, front or behind. The whole world will still, till today, whole world will do foramen magnum decompression for this. My impression is absolutely clear and no hesitation, no doubt that C1, C2 stabilization is the treatment. It is difficult, it is complex, but it is the best. We introduce another thing, like even when facetal alignment is maintained, even when there is no atlantodental interval disturbance, presence of Chiari, presence of syrinx, presence of assimilation of atlas, platybasia are all indicators of atlantoaxial instability. Atlantoaxial stabilization is the treatment, and you get a magical radiological outcome and an absolutely magical clinical outcome, like patient can improve in the immediate postoperative period in a dramatic or a magical fashion, like you have never seen with decompressive surgery. So type 2 and type 3, I call central instability when there is no atlantodental interval disturbance. Facetal malalignment in this situation, no malalignment, you can have clinical parameters, radiological telltale evidences, and intraoperative observation of instability will give you the diagnosis of central instability. So instability and basilar invagination are atlantoaxial instability is the cause. Basilar invagination is secondary, it is protective, it is reversible, like many other so-called pathological entities. So we have produced several articles on this subject of basilar invagination, both group A and group B, and atlantoaxial stabilization is the treatment for both these clinical entities. There is no role for decompression, which still quite a number of neurosurgeons in the world perform it, but there is no hesitation for me to say that this is the treatment for basilar invagination, both group A and group B. Now you see here, there is Chiari, there is syrinx, there is some facetal malalignment type 2, there is no atlantodental interval disturbance. This is to, nobody looks at the facets, but facets can be malaligned. Whether they are malaligned or not malaligned, presence of Chiari, presence of syrinx is an absolute indicator of atlantoaxial instability, absolute indicator for atlantoaxial stabilization, and the syrinx will reduce in 100% of patients if you see an image after about 6 months of surgery. Sometimes you can see reduction in syrinx after 2 days of surgery. Reduction of syrinx is all right, but patient will dramatically recover in clinical symptoms in the immediate postoperative fashion in a manner which is just unbelievable and unimaginable by any other kind of surgery. So there is no atlantodental interval disturbance, mild facetal instability, Chiari and syrinx. There is absolutely no role for decompression. You do stabilization, syringomalia will reduce, and of course the patient will dramatically recover. Even when there is no atlantodental interval, no problem in facetal alignment, presence of Chiari, presence of syringomalia, presence of basilar invagination, assimilation of atlas, clear indicators of unstable atlantoaxial joint. Stabilization is the treatment. And syrinx can recover, reduce in quick and in definite pattern in post-operative period. Whether the syrinx recovers or not, that is not our issue. The patient will recover dramatically in immediate post-operative period. So this is syringomalia. You see, this is on the 3rd day of surgery, and this is delayed, how the syrinx reduces, and the patient dramatically recovers. So we wrote about this in several articles of ours, that Chiari, basilar, syrinx are all related to atlantoaxial, which is the father of these children and many other children this father has produced. Atlantoaxial instability. This article had created quite a flutter in the world of neurosurgery, and still it is being discussed and heavily discussed, but I have no hesitation to recommend that atlantoaxial instability is the cause of Chiari, and atlantoaxial stabilization is the treatment. Many people talked about that only complex Chiari can be treated by stabilization, only when there is basilar invagination that can be treated by stabilization. I wrote this article a few years ago when there were no bone abnormalities. I treated by atlantoaxial fixation, and whether there is bone abnormality or not, whether there is syringomalia or not, whether there is basilar invagination or not, presence of Chiari in discretely and in cohort with others are clear indicators of unstable atlantoaxial joint. I recently wrote with my colleagues this article a few years ago, where my series of 388 patients with dramatic 100% clinical result of dramatic clinical recovery following atlantoaxial stabilization. So in short, I have no hesitation to recommend that Chiari is the problem related to atlantoaxial instability. Atlantoaxial stabilization is the treatment. Decompression in the presence of unstable atlantoaxial joint is a negative form of treatment. I have treated one Sri Lankan patient also of Chiari. So obviously my message has gone to Sri Lanka also regarding Chiari malformation. When you do foramen magnum decompression, I was also doing foramen magnum decompression. Now many of my patients, my own patients, have returned for persistence of symptoms, and I have got several other patients. So I wrote this article where foramen magnum decompression has failed, and I have treated them with atlantoaxial stabilization with dramatic. There are some beautiful examples like this one. This was a very fantastic engineer who was operated 13 times with various surgeries. You can see the shunt here. You can see 3 times decompression. First only foramen magnum, then C1 was removed, then C2 was removed, and this patient was treated 13 operations, ventriculoperitoneal shunt, 3rd ventriculostomy, and various other things. And I did this fixation, and this patient, I have been able to give him a wonderful, wonderful new life. So I like to call it Chiari formation because it is protective. It is not a malformation. It is protective airbag. Similarly, syringomalia, I have said, and this has produced quite a bit of, controversy or whatever, but not many people are now doing shunts and syringoperitoneal or syringopleural shunts now. And I have said that this is helpful, not harmful. Chiari malformation in pediatric age group, syringomalia in pediatric age group. Many people argued with me when I wrote this article that it will not work in pediatrics. So we wrote this article with my experience on pediatrics. Now I've got several patients with pediatric Chiari and pediatric syrinx, which is more dramatic recovery I get in these patients. And this is one such child where I did C1, C2 fixation with a dramatic clinical outcome. Idiopathic syrinx, nobody in the world knows what is to be done and how it is to be treated. Shunts and all those things have been recommended. You see, there can be instability and there is absolute recovery following only stabilization. So this is our article on this subject. A revolution. There is No second word that comes in my mind. Cervical fusions are secondary. Cervical fusions are protective. And cervical fusions are potentially, I have never seen any case where cervical fusion, but I have mentioned in this paper that cervical fusions can be reversible, potentially reversible, and cervical fusions indicate atlantoaxial instability. There is no compression, but I have done C1, C2 fixation. These are secondary, these are protective, and these are potentially. Of course, this will not recover, but potentially recover. This is what we have mentioned. Most important than any of these things, a dramatic clinical recovery from symptom. Dramatic. A person who was not even breathing properly, not able to talk loudly, has now started gone into college with beautiful voice and beautiful breathing. Bifid anterior and posterior arch are indicators of atlantoaxial instability. They are protected, they are reversible, and the bifid can fuse after atlantoaxial stabilization. I must let you know that there is a lot of controversy about how to treat bifid in the whole world, but there should not be any controversy. When you see bifid, you do atlantoaxial stabilization. When you see fusion, when you see bifid, the diagnosis is C1, C2 instability, even when there is no compression, and the treatment is stabilization. Os odontoideum, very big controversial subject and treated in hundreds of manners, particularly in Western countries, by decompression and other things. We have said that os odontoideum is secondary. It is secondary to atlantoaxial instability. It is protective. It is self-destruction, self-sectioning by nature. You do it stabilization, this will fuse, and this is the treatment. There is no indication for decompression like many people in the West are still doing. There is no indication of occipitocervical fixation that many people in the West are doing. You do just C1, C2 fixation. That is the treatment. So short neck, short head, short spine are all secondary to atlantoaxial instability, and stabilization is the treatment. So short neck leads to torticollis. You do C1, C2 fixation, the neck can become straight in the evening of operation, and you can get this kind of broad smile and king-like posture with long and straight neck if you understand this problem. If you do not, you can create devastation in the patient. So long-standing musculoskeletal abnormalities like short neck, torticollis, and all these kind of things are due to atlantoaxial instability. You stabilize and you create these kind of wonderful patients. And you create these beautiful smiles, even if it is not exactly a smile. When you have short spine, you can have this kind of kyphoscoliosis. And when you have kyphoscoliosis, many people will do big rods, multiple screws in this age group, my dear friends. More than 80 or 85% of patients in this group have central instability, even when there is Chiari or not, or syringomalia or not. These patients have central instability. You do C1, C2 fixation. In the evening of the operation, the whole body can become remarkably, of course, not completely because these are fixed deformities, but there can be remarkable recovery. So central or axial instability is a definite cause. By itself, it can be a cause of symptom of quadriparesis and all those things, and you have to identify this clinical entity. So presence of syrinx without any problem, without any compression, can be an indicator for atlantoaxial stabilization. Bifid in the absence of any compression is an indicator of C1, C2 fixation, and you can have quite dramatic clinical outcome if you treat them with philosophical method of treatment. So I'm saying foramen magnum decompression can become an absolute historical operation, and there is no hesitation to say that time has come to take this to history. Now I want my Sri Lankan, I will want to go to next chapter of my spine surgery about cervical spondylosis. Do you have any questions to ask me? So please ask me at this point about craniovertebral junction. Is there any question? John, no questions?
Okay,
Saurabh,
hold on. I think Sarath has one.
Saurabh.
Right. I want to ask one question now. When we talk about C1 C2 fusion, it's I mean, whether it's a C1 lateral mass screw, a C2 pedicle screw, I mean, it doesn't matter. Whatever I mean, what do you recommend? Is it a facet screw?
Do you know about my technique or no?
Yes. Yeah, that's what I'm asking.
So that is the best technique, and the whole world is saying that is the best technique, Saurabh.
Yeah.
And if you have to treat C1, C2, you have to do the best technique. So there is no other option other than treating with the best treatment. And if you do midline wiring, occipito-cervical fixation, occipito-subaxial fixation, those are absolutely suboptimal kind of fixation. And transarticular Megal's technique is not a bad technique. It is a good technique, but there are some issues with that technique. I think the best technique is the C1 facet and C2 facetal fixation.
Yeah.
My technique involves opening of the joint. My technique involves denuding of the articular cartilage. My technique involves introduction of bone graft in the joint cavity and then fixation. That is, this kind of a rigmarole has to be done if you want to have a solid fixation. If you don't manipulate the joint, if you don't put bone graft in the joint, that I call suboptimal kind of fixation. Saurabh.
Yes. Agree. Thank you very much.
I'd like to see your associate in Mumbai, Harshad Parekh. Harshad, are you there?
Harshad.
Yes, John, I'm there very much.
Oh, very good, very good. Hello, welcome.
Harshad, I want you to ask me some question.
Atul, no, you yourself are a question. Where to ask you question? you are revolutionizing.
Yes.
Excuse me, I have a question.
Go ahead, Saeed. Go ahead.
Thank you very much for this wonderful presentation as usual. I want to know, have you ever noticed some visual problems after surgery of in patient with significant head tilt?
Visual problem, you know what, visual problem can occur following surgery if you have inadvertent damage to the vertebral artery. And if you compromise the caliber of the vertebral artery, you can have postoperative. But that is a huge complication that should not happen. But if you have done a good fixation, if you have done a beautiful fixation, then vision should not be a question at all. Right?
Yeah. I think about because in the child perhaps there is no problem, but in the adults who are significant head tilt for many years, they are adapted with the time. But
yeah, see, the thing is, if there is a person who has short neck,
yeah,
if the person who has torticollis,
yes, like I talk about
if the person who has, various manifestations radiologically, like fusion, like platybasia, like assimilation of atlas, C2-3 fusion, like various other bifid, if they have no symptoms, it means they are completely adapted to the whole situation. They might be patients who have Chiari, but they have no other symptoms. There may be patients who have syringomalia, but they have no symptoms. But these patients have atlantoaxial instability, and there is a potential for worsening of symptoms. If the patient has long-standing head tilt without any other symptoms, you might possibly like to observe him. If there is a Chiari, but this patient should be watched carefully because the symptoms might progress and symptoms might come in. If this patient had a head tilt without any, you might see after 6 months he comes with tingling paresthesia in his fingers. And then after 1 year, he might have come with a wrist weakness and finger weakness. After 2 years, he comes with spasms of his legs and stiffness of his legs. After 2 years, he might come with difficulty in speaking, and then he comes with sleep apnea. So these are chronic atlantoaxial instability. Natural reparative methods come into picture. The symptoms might occur slowly, but they are relentlessly progressive. Maybe subtle, but they are progressive. If there are no other symptoms, only neck tilt, it might be an option to just observe him. But if for last 6 months he's complaining of some paresthesia in fingers, some weakness in the hands, then he needs surgery.
Okay, thank you very much. Thank you very much.
Okay, so now I go to my next chapter, John. Okay?
Yes, yes.
Okay, now I want to introduce another revolution to my dear Sri Lankan friends. And of course, there are others who are not from Sri Lanka. I can see some on the screen. I want to talk about degenerative spine. And I must first let the people who are listening to me know that I wrote this chapter for Sweet and Schmidek, which is a very well-known book in neurosurgery about anterior surgery. And I was doing anterior surgery quite commonly and quite frequently in my surgical domain. And this kind of anterior decompression, this of course has not been done by me, but this kind of anterior surgery were common in my surgical list. And anterior surgery, osteophyte removal, anterior decompressions were common. And I also introduced these kind of tricortical screws about 25 years ago. These kind of tricortical standalone screws. And these I consider quite beautiful screws. But as our understanding grew, as our information about biomechanics of the area grew, as our understanding of instability issues grew, as our understanding about facetal anatomy and facetal, how the facets are important, how the disc is not the issue. Disc, I wrote this article about praying the disc, about disc reverie. The disc is divine, nothing can happen to the disc. Disc is never an issue. Problem is, these muscles become weak and there is a listhesis at the facets which may not be radiologically identifiable, and the changes that you see in the disc are secondary. Osteophyte formation is secondary. Reduction in the canal size is secondary. Reduction in the spinal canal size is secondary to vertical telescoping at the facets. So that is an issue. So degeneration at craniovertebral junction has actually never been discussed in the literature. We mentioned that degeneration atlantoaxial joint is most mobile. Degeneration of the atlantoaxial joint is the most common form of degeneration. And I wrote this article about 15 years ago. I want you to see carefully this slide, which is my prime slide, and I like to show this slide often. Reduction in the joint space, buckling of the posterior longitudinal ligament, osteophyte formation are not primary events. They are secondary. They indicate atlantoaxial instability. Atlantoaxial stabilization is the treatment. So this reduction, this buckling, this osteophyte are secondary. They are protective. They are reversible. Although they look pathological, they look like compressing. You see, this cord compression looks like a very dangerous issue but these are not the primary issues. The problem is C1, C2 instability, and stabilization is the treatment. Decompression is not the treatment. Like ossification of the apical ligament, osteophyte here are not the issue. The issue is instability and the treatment is stabilization. Any form of decompression is a negative form of treatment. This retroodontoid pseudotumor, this is secondary. This is like an osteophyte of the craniovertebral junction. It indicates C1, C2 instability. It indicates the need for C1, C2 stabilization. There is no need for decompression by transoral or foramen magnum decompression. I can tell you, my dear friends, you do foramen magnum decompression, this patient will turn out quadriplegic. You do foramen magnum anterior transoral, there will be no clinical recovery. There may be a potential for worsening. You do C1, C2 stabilization. You find a magic that you have never realized. You do anterior transoral surgery for this, you will not be doing any good to the patient. You do foramen magnum decompression, you have killed the patient. You do C1, C2 fixation, you have given him new life. So this concept completely revolutionized treatment of retroodontoid pseudotumor. The whole world, many of the world still doing foramen magnum decompression and transoral and endoscope and lateral and all those kind of, but this is an indicator of atlantoaxial instability, and stabilization is the treatment. Similarly, retroodontoid cyst, if you do foramen magnum decompression for this, if you do transoral, there is no, this is an indicator of atlantoaxial instability. This cyst will automatically disappear as early as immediate postoperative period. So you see clear indication of unstable central instability. This cyst, very easy to operate by just puncturing of the cyst, which is not indicated. You do C1, C2 stabilization. And we have got several patients where we have done with only stabilization. This kind of retro C2 cyst, and you see this is a hole punched in the body of C2. There is a dynamic process. You do flexion, this cyst goes inside. You do extension, it comes out. So this is a dynamic, only treatment is C1, C2. There is no need to remove this by any maneuvering. And this syringe is also secondary and protective. So we have got several patients like this where we have given new life, an absolute magical life. And I wrote this article with my 63 cases, and I wish that you please read this about what is spinous, what is cyst, what is pseudotumor, and what is the treatment. There is no treatment of decompression. Pannus, the whole world was rheumatoid pannus, the whole world was treating by decompression. Of course, now drugs are beautifully have taken over the treatment, but this pannus is due to vertical instability. You have to do stabilization. This pannus will disappear as early as immediate postoperative period. We introduced intra-articular spacers as a very effective treatment for atlantoaxial stabilization and called it joint jamming technique. Some of you must have at least heard about it. So facets are the strongest point of the vertebra, not body, not spinous process, not transverse process, not pedicle. So we have to use facet for fixation. And we introduce a very beautiful concept for spinal degeneration. Carefully see this. We talked about C1, C2 as a cause of basilar invagination. We also identified instability or facetal listhesis as a cause for spinal degeneration. Muscle weakness is the problem. Listhesis at the facet is the issue. Osteophyte formation, disc bulges are all secondary. They are all protective. They are all reversible after facetal fixation. So carefully see this slide. Reduction in the intervertebral body disc space, osteophyte formation, bulging of the disc are not primary phenomena. Don't have to do multiple discoidectomy, corpectomies, laminectomy. They are indicators of several segments of instability. There is no need to remove the osteophyte, stabilize, and this will spontaneously recover. Instability is the issue and stabilization is the treatment. So vertical instability is the issue. It is the point of genesis. So I have no hesitation to say that this article, as small as it may appear, completely revolutionizes degenerative spine surgery. This kind of single level, you will certainly like do ACDF, come remove the disc and then do fixation. Not a bad treatment, but this is not required. There is no need for removal of the disc. No need to remove the osteophytes. You do interfacetal. This is what we described about 15 years ago. That just facetal distraction and arthrodesis can be the treatment. And this is immediate postoperative. You see the new disc, this ligamentum flavum is straightened and everything. So this was the genesis of an alternative hypothesis for spinal degeneration. Similarly, you see ligamentum flavum buckling, posterior longitudinal ligament buckling, and you see this immediate postoperative result, the whole thing, multi-segmental interfacetal spaces. And we have got several articles and several papers and several cases where we have done this single level, multiple level spinal degeneration for radiculopathy and for myelopathy. And the aim is distraction, fixation, stabilization is the result, is the aim. And we have treated several patients where radiological cure is instant. Clinical cure is more instant and more pronounced. And the aim is arthrodesis. There is no role for decompression as treatment, neither anterior corpectomy, nor posterior treatment, nor laminectomy, nor laminoplasty, just fixation, stabilization. And you see after, this is immediate postoperative, you see how the cord has changed, and this is the beautiful. So I wrote this article in Journal of Neurosurgery, and many people in the world, even the topmost institutes of the world, there are some reports that they agree and they are following this kind of treatment. They use different implants, but I have produced my own implants. And facetal distraction spacers, it has new hypothesis of spinal degeneration. So these are my spacers. These are patented in India and in US and in various other countries. I have to say that these spacers is a remarkable thing on the basis of anatomy. And you see here, this is multi-segmental degeneration, as you like to call it. And this is postoperative, and this is intrafacetal spacers. And you see how beautifully the canal has changed. So you can imagine from compression as pathology, I'm saying compression is not the issue. From decompression as the treatment, I'm saying decompression is not the treatment. I'm saying that distraction, reduction, fixation is the treatment. This is what I had said 15 years ago. And I will tell you what I'm saying now. Even disc herniation can reverse. You see, this is a disc. The whole world will do anterior surgery, but you do stabilize. There is immediate postoperative, and this article I wrote in World Neurosurgery. Same concept. Multi-segmental degeneration or canal stenosis, as you like to call it. I said that this is due to weakness of the muscles, that these are secondary issues. This stenosis should not be called stenosis. You have to introduce spacers, and no decompression, and this is the treatment. And this was published in Journal of Neurosurgery about my experience about 15 years ago as to what I did for lumbar canal stenosis. So decompression of compressed and deformed neural structure is the basis of treatment for spinal degeneration for several decades. But now I'm saying not even distraction is necessary. Instability is the issue, and only fixation is the treatment for cervical degeneration in 2013. So 10 years ago, I said this, that you don't even need to distract. You just do fixation, and that is the treatment. And more recently, in 3 years ago or 2 years ago, I wrote my article with 215 cases in World Neurosurgery. Muscle weakness related spine instability is the cause of spinal degeneration, and spinal stabilization is the treatment. A dramatic new thought, and no decompression. So this is multi-segmental degeneration. Many people in the world will do corpectomy and discoidectomy and all those things. You do only fixation, the whole anatomy will change more faster than you can imagine. Essentially, what I'm saying is there is no need to do all these kind of maneuvers of corpectomy and all. There is no question of doing laminectomy and all. Just do stabilization. And you see the dramatic radiological recovery, and more than that, a more dramatic clinical recovery. So degenerative myelopathy, we should look with a different eye, not just of compression and decompression. So we said that is the symptom of cervical and lumbar radiculopathy and is an evidence of spinal instability? Yes. If you see cord atrophy, you will label as some demyelination and all those things, and you may lose an opportunity to treat this patient's instability. So instability is the cause of symptoms, and stabilization is the treatment in degenerative spine. Another beautiful sentence I want to show you to you, it is not neural deformation or compression, but instability is the cause of symptoms in degenerative spinal disease. If the patient comes with symptom of radiculopathy, even if the radiograph, if there is MRI is showing nothing, you cannot say, okay, do massage, do all those things. There is a possibility of treating this guy by stabilization. So there are clinical guides, there are radiological guides, there are intraoperative guides to identify instability and treat instability. So I do Camille's technique of transarticular fixation. Sometimes in cervical, I normally don't do put 2 screws, but in lumbar, I put 2 screws and sometimes 3 screws. So what are the indicators? This is the most critical issue in degenerative spinal disease. What are the indicators? How many segments you will fuse? That is the critical in my eyes. Like here, there are 2 levels of degenerative, if you want to call it osteophytes and all. You come for 2 level stabilization, but I have done 4 level of stabilization. So which segments are unstable? That is the most critical issue. And you have to read my article on this subject and you will identify what are my indicators. So there are multi-segmental, and you see this is the beautiful clinical outcome. There is no decompression, only fixation. And I have got several 100 patients now where I have not done decompression. Another potentially revolutionizing issue is when you talk of multisegmental degeneration, you never talk of atlantoaxial instability. In my calculation, atlantoaxial instability is more often than not associated with multisegmental degeneration. So this kind of instability, there is no compression. Compression is not an issue in spine surgery. Just compression, 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 and decompression can take you several years behind in your treatment. So this kind of multiple, there is no problem here, but you see the facet, you have to include C1, C2 in your fixation construct. You cannot avoid. There is no decompression. When the patient comes with severe myelopathy, patient comes on a wheelchair, patient comes on a stretcher, more often than not, atlantoaxial instability is associated. You have to include atlantoaxial stabilization in your fixation construct. If you want to send him home walking in your hospital, he will start walking if you treat this patient in an appropriate philosophical fashion. So we have introduced this alternative technique of C1, C2 fixation, where we do C2, 3 fixation and remove the muscles attached to the C2 spinous process and then do fixation. And here there are multi-segmental fixation without any form of decompression. And you see here this ligamentum flavum, and I have done fixation at 4 levels, here 2 levels, but dramatic clinical outcome. Similarly, lumbar canal stenosis. This article was published in Neurosurgical Focus. So carefully see, these are published material which I am showing you. I'm not showing you hypothetical, some kind of abstract thoughts. Lumbar canal stenosis is a result of multisegmental instability. And you see the title, Role of Stabilization, Futility of Decompression. And you see this kind of multisegmental lumbar canal stenosis. These bulges are secondary, these are protective, these are reversible, and you have to do only stabilization. I introduced Camille's technique, and I do sometimes 2 screws, sometimes 3 screws at each level. And this is a very fantastic method of stabilization, a beautiful no decompression, and a dramatic clinical outcome. So you see these 2 screws at each level. And this is published in Neurosurgery. This is published in Journal of Neurosurgery. The question is it necessary to remove the osteophyte? The whole world of spine surgery, the main focus is to remove the osteophytes by anterior surgery or do laminectomy to accommodate these osteophytes. I'm saying osteophytes are divine. Osteophytes are protective. Don't disturb them. They are indicators of unstable spine. And this was my article published in World Neurosurgery as what happens when you do only fixation. and what happens to the osteophytes. And this is a beautiful article. You must read, my dear friends, my various thoughts. I'm just giving you a small glimpse of what my impression is, and you see the clinical outcome. And many of these papers, many of these images are published in World Neurosurgery and various other journals. So is the term spinal stenosis a misnomer? Absolutely. It is unstable spine. Stabilization is the treatment. Deformities of cervical spine. These kind of deformities and kyphosis, the whole world treats with kyphectomy and all those kind of things. Identify these are secondary. These are indicators of segmental or multi-segmental instability, and identifying the unstable segments and treating is the treatment. Decompression is an absolute useless thing. So here in this case, there is C1, C2 instability. Here in this case, there is subaxial instability. Here in this case, there is central instability and subaxial. So you have to please read this article of mine. Beautiful article, revolution. This kind of kyphosis, there is no decompression. There is no other treatment other than multi-segmental stabilization. I now introduce to you another very dramatic concept of prolapsed disc. Prolapsed disc, in my estimation, disc is divine. Prolapsed disc is an indicator of unstable segment. Prolapse of a disc is due to instability, or it causes instability. Like you wear a cervical collar, your pain will go. You wear a lumbar belt, pain will go. You show slightest movement, there will be severe pain. So it indicates unstable segment. Only fixation and only stabilization. So you see this beauty of these articles. If this kind of single level disc has herniated, the whole world today will remove this disc by ACDF and all those things, which may be quite result oriented, but you do only fixation without even struggling with the disc, and you see the most dramatic clinical outcome that you have not imagined. So this article is published in World Neurosurgery about only facet fixation and arthrodesis as treatment for cervical radiculopathy. Similarly, lumbar radiculopathy, we treated with only fixation. You do only fixation, identify, and this disc will disappear in no time. In about 3-4 months, the disc will disappear. Identify, this may not be the only unstable segment. The upper segment is also unstable. So 2-level segmental stabilization, and there is no need for removal of the disc. This is my confirmed, fixed, definite hypothesis, and we have treated several patients with this kind of problem. Similarly, lumbar scoliosis. I treated a very high profile, a president of one country who came to me with this kind of kyphosis, and the whole world was telling that you should do decompression and all those things. I treated only dramatically beautiful outcome by only stabilization without any kind of decompression. Another last thing which I'm going to talk about, OPLL, the most dangerous, the most difficult treatment. I am saying that ossification and cervical spondylosis have the same issue. These are secondary to unstable spine, and only stabilization is the treatment. We have treated ossification by various forms of treatment. I have introduced for the first time oblique corpectomy several years ago, but today what I'm saying is that there is no need for any kind of corpectomy or laminectomy. Only stabilization is the treatment. This I mentioned about 15 years ago, and more recently I published my series with 52 cases where there is no kind of decompression, only stabilization as the treatment. This kind of, don't do any laminectomy, don't do any corpectomy, just go and do a very simple operation of Camillus technique, multi-segmental, identify the unstable segments and stabilize them, and you create a magic. Atlantoaxial instability is more often than not associated with cervical in OPLLs, and you have to include C1, C2 in your fixation construct. So there is instability, there are osteophytes, not osteophytes, OPLL, and you want to improve that, you want to give a magical treatment. This is the treatment. Decompression can kill the person. Anterior surgery can make quadriplegia. Posterior decompression can make quadriplegia. As I was talking in retroodontoid pseudotumors, similar issues can happen in this situation. Don't do decompression. negative treatment. I'm not sure how many of my Sri Lankan friends have treated OPLL, but if you have treated 5 cases by decompression, you promise me, you tell me the truth that at least 1 out of the 5 must have got severe quadriplegia or quadriparesis following surgery. You just look into your own cases. I have no hesitation. If you have done more than 5 cases, 1 of these 5 cases must have got quadriplegia. And if you are saying no, nothing has happened, I will not believe you. So these kind of things you have to treat by only stabilization. So atlantoaxial and subaxial cervical spine fixation can revolutionize the treatment for OPLL. And Camille's technique is the best. You can introduce 2 screws, you can introduce 3 screws. And you see here in this case, there are 3 screws for lumbar spine. Cervical, I do with only screws. So facetal fixation is the key. Facetal fixation is the strongest. And decompressive laminectomy and corpectomy can just disappear into wilderness and history. In my view, they have already. So cervical spondylotic myelopathy and OPLL, the treatment is only stabilization. So like anterior transoral surgery, we demolished it. I am ready to demolish anterior cervical surgery as a complete for this kind of laminectomy, this kind of laminoplasty, this kind of corpectomy can certainly disappear. So from only decompression to only fixation, this has been the journey of treatment of spinal degeneration. And atlantoaxial and subaxial, it can certainly revolutionize treatment of degenerative spine and the treatment of OPLL. So my dear friends, compression is never primary and decompression is never the treatment. So thank you very much. And I know that there will be several questions, but I request you, I know I have presented a dramatic kind of different view of spine. I want you to read my articles. I don't want you to just start arguing with me or questioning me and all those things. I am available. John will invite me again 10 times. He has the key to my invitation. He will invite me. You keep your questions. You first read my articles. I have just given you a glimpse of my work. I have just given you a very short summary of my work. But as per the norms, I will take few questions if you have now.
Okay, thank you, Atul. Okay, the floor is open. Omar, good day, Omar. Oh, I'm sorry, go ahead, Saeed.
How are you?
Yeah, thank you very much, Professor Atul. It's a very wonderful presentation.
Thank you.
I have always wondered how to properly treat my patients with straight cervical problem. So when we operate the patient with the anterior arthrodesis, excuse me, we move the problem below or under the level. I'm convinced that your technique is the best for this problem, to avoid to move the problem and the level, and after you operate the next level, and we moved because we put the cage. And usually the cage is more higher than the height of the disc.
Yeah.
So I'm convinced that that's will be a very good indication for such a.
Thank you very much. Thank you very much. I wish the young people, at least younger people in the audience, can, try to understand. You see, this is different. This is a completely different form of treatment. This is complete, I call it complete revolution in spine surgery. You see, the whole world tries to remove the disc. I try to do decompression, laminectomy, corpectomy. The whole world is doing. From anterior, from oblique, posterior, from O-leaf, P-leaf, T-leaf, all kind of things are there. But the aim should be only stabilization, and decompression should not be. This should never be touched. This is not the issue.
Thank you very much, Professor Atul.
I have one comment. Thank you very much, sir. And it was a fantastic lecture, fantastic talk. So I have heard this before quite a number of times, but it's I mean, it's when you hear that again and again, it's been really wonderful. So one comment regarding OPLL, as you mentioned correctly, I have done around 15 cases of OPLL up to now, and I have done 10 corpectomies and 3 or 4, both anterior and posterior. Out of that 15, 3 patients had became quadriplegic. One case of white cord syndrome as well. So actually, I could not understand the reason behind that, because one case, one patient, the last time 2 weeks back I presented that case, we had a discussion. So that was done posteriorly, the fixation. And that patient got hyperperfusion, a white cord syndrome after that, and she became quadriplegic. And the other 2 cases I did anteriorly first and then came posteriorly, but still the patient got worse. So actually, I did not understand the reason behind, but now after your lecture, I understood the reason behind that. So I quite agree with you on that.
Thank you, Saurath. And I am happy that you know what, as I mentioned to you, I have done corpectomies. I have talked about oblique corpectomy for the first time in the literature. This was my article. I have talked about decompression. I have talked about floating OPL, means posterior longitudinal ligament. I have talked about CSF leakages. You can see my articles on the subject. But I am telling you from bottom of my heart, with all the truth that I can muster, with, absolute revolution is there. You know what, Saurath, you are a younger neurosurgeon. If you do only Camillus technique, it is a very straightforward technique of fixation. You have done fixation. Suppose your result, you have not got the desired result. Suppose you are not happy with the result. Suppose the patient is not happy. You have already done fixation. You can come from front and do decompression anytime. You can come from front, you can do from behind anytime. But I am telling you, from the last several years, I am doing only fixation. I have never needed decompression as a second stage operation. I have never needed. So you know what, I am having fellows from all over the world. I am not sure if I saw Mohammed. Mohammed, you are there on the screen? One of my recent fellows from Libya. Mohammed,
Yes,
no?
yes.
Oh,
Yes.
you are there. So I am happy to see you are in a car, I believe.
Hello.
Huh? So Mohammed,
Yes, but I'm listening.
So you can make some few comments before I move on.
Yes, I will. Thank you so much for the speech. And as I said once, I promise I will always be a good listener. So please keep talking about this. And I have a small comment about something like I'm waiting for a good news for the book. So just a small reminder.
Okay, it will come. Okay. The book is coming. It's coming, and it will start again now.
Yeah, hopefully. Yeah, thank you. Very good talk. I'm actually
Thank you,
inside the
Mohammed.
car
Thank
with
you.
my brothers now.
I can see the car and just enjoy the ride. Okay, Mohammed?
Thank you.
You know, Atul, before the last webcast, I was speaking with Mike, the husband of the woman you operated on from Vancouver, Canada.
Yes.
And I didn't know if it was appropriate to bring him into the discussion or whatever. However, I think I just mentioned it because he was happy. And I think it's about what you're talking about, fixation, correct? 2 titanium plates that you put on.
Yes. So, John, you are taking my message throughout the world, and I am happy to give this message to Sri Lankan neurosurgeons today. And as I mentioned that I have been talking about cavernous sinus, I have been talking about petroclival tumor surgery, I have been talking about intraventricular tumor surgery, but I have never actually talked much on spine for pituitary tumor surgery, my favorite. John, maybe I can talk on pituitary tumor next time if you have an give me an opportunity to Sri Lankan neurosurgeons.
Sure.
And I can talk on cavernous sinus. So spine is a wonderful subject. Spine can just make or break the human. If you talk of tumors, tumors can demolish the person by themselves. But in spine, the surgeon can demolish the person. So we have to be absolutely good. We have to understand spine. You cannot just say, okay, we can do, I can do. You have to understand spine in a very right perspective and then treat. You cannot just arbitrarily treat by, okay, I see radiograph, there may be here, there may be there, and you treat, incompletely. Your patient will never improve if you have not treated properly. So in short, we have to understand spine, we have to treat spine, and I know there may be several questions, I know, but I will be awaiting questions. Maybe as John had organized one special webinar for me where the only questions were asked to me. Maybe I can have John, after some months of talking here and talking there, a complete session where only questions are asked and I answer them on tumors and about spine and on various other issues. Okay, John?
Okay, we'll address that as time unfolds.
Okay. Okay, John. So
Okay. Go ahead, Dr.
I thank you for taking these webinars to a new dimension. I thank you for taking neurosurgical education to remote corners of the world. You have given me opportunity to talk to neurosurgeons and I went recently to, as you know, into Latin America, and I was surprised how many people from Bolivia knew me or from Uruguay knew me, and they have heard me on occasions, and they came to meet me, and it was very beautiful. And I thank you, John, for taking my message throughout the world. Thank you, and best wishes to all of you. And I wish you read some of my papers, and bye-bye to all of you.
Okay, thank you,
Thank
Atul.
you. Thank you very much.
Thanks,
Thank you
everyone,
very
for
much.
coming. Stick around.
Thank you all. Thank you, Doctor.